Good morning, everyone. My name is Jean-Christophe Richard. I'm an intensivist working in Angers University Hospital in France. And my pleasure to moderate this session this morning on acute respiratory failure. We are 1 minute before the first presentation. As you know, there is no doubt that the situation we faced during the pandemics was completely new practices, new knowledge, and it changed very rapidly. But the question this morning is acute respiratory failure associated with COVID, a different syndrome requiring a specific strategy, very important question. And to address this question, my pleasure to welcome Luciano Gattinoni, the father of the baby lung and the expert on this topic, and Neil Ferguson, coming from Toronto, Division of Critical Care Medicine, Mount Sinai Hospital. And Luciano will start with trying to convince us that we need a specific approach, I suppose. Thank you, Luciano, and welcome to the audience.
Okay, thank you, Richard. I don't want to convince anybody. I just hope that maybe the people with different opinion, or with the same opinion that I have, maybe to raise some doubt about this story, because for a given disease, not a syndrome, because COVID-19 disease is equal everywhere in all the world, that after almost 2 years, we do not have a consensus about respiratory treatment, should make us thinking. Why? Now,
Luciano, sorry, you can remove your mask if you prefer.
Right.
It's better to hear you. Thank you.
Now, I think that our, let's call intensive care community is divided sharply in two. If RDS is typical, the problem is no, we don't have any problem. We use a typical treatment of RDS, which is lung protective strategy, higher PEEP, and so and so. If it's not RDS typical, let's call RDS for convenience, the COVID-19 is something different, the treatment maybe requires some adjustment. So it's not an academic question. Is a question which is of real importance. And I remind you, the mortality in intensive care for this, which is the same disease, goes from 10 to 90% for the same disease, which means the treatment plays a fundamental role. Now, pneumonia, typical RDS. I spent a little bit just to summarize. We changed the definition and so on, but the basic of the RDS are that different diseases may lead to a common picture, which is edema, which steals the space to the gas. The gas is reduced, and we have the baby lung. Having the small gas, we have a problem with gas exchange, because to eliminate the CO2, we have to strain a lot the lung, and of course with the shunt, the true shunt, going through the non-aerated lung regions. Being the small lung small, the baby lung, the compliance, which is a measure of the lung size, is reduced at different extent, and the heart has some problem to pump against lung in this condition, full of edema and so on. And so we have the problem with the right heart. But please remind you that all the data we have about RDS, more than 80% derive the observation of two populations, which are the bacterial pneumonia and which are the abdominal infections. All the rest, virus pneumonia, immunodisease, smoke inhalation, Mendelssohn disease, etc., have just minor incidence. So all our study derive from this population which has present this kind of characteristics. And now on the scene we have the COVID-19 pneumonia. At the beginning, these are, I think, only 16 patients. Other people say, oh, 16 patients, we have 60,000 patients, good. I remind you that ARDS was described in 12 patients. And I remind you that all the pathophysiology studies were never exceed 20, 25 patients. Tell me one randomized study that gives us some information about pathophysiology. I'm not aware of any. And on these 16 patients, we found that more than half had compliance greater than 50. And the people say, so what? We know in mild ARDS, sometimes we have the compliance. Good. But the shunt, the venous admission, was always greater than 30%. That means very severe ARDS. So we have a flexible lung, whatever people taking care at the beginning of the patient, because the time is fundamental in this disease. In the early stage, flexible lung, even the mass media was speaking about no problem to ventilate this patient. White ARDS, one of the typical of ARDS was a stiff lung. So the problem is not the compliance per se, but the dissociation between the gas exchange, the deep hypoxemia, and a lung which is full of gas. Now, my dear friends, the gas exchange in mathematics. If I have a gas-filled lung and I have deep hypoxemia, I have only one possibility, unless I'm breathing FiO2 very low or in the Everest Mount. And the possibility and the explanation is on the vascular side, on the perfusion side. No other reason. And this is not in the classical ARDS. Anyway, this was the point that make us to think, wait a second. This is not what you are accustomed to observe. But the people jumped on the first part, on hypoxemia. What is the classical intervention of hypoxemia? Up FiO2, good, and PEEP. I take the table and I put a PEEP of 15, 16, 20. In my region, Lombardia, the first wave, the median PEEP was greater than 14. In patient in which the gas volume was a little bit higher than the baby lung. Look here, these are, will be published, I think, very close, has been accepted after big fights on intensive care. And you see, this is the PO2 PF, are under 40 patients, if I remember, in different groups. The classical non-ARDS, mild ARDS, moderate, mild moderate, moderate severe, below 150, and severe ARDS. And you see you have a beautiful line, the PO2 goes down. And look down is the lung weight and the proportion of the CT scan. You see that in severe ARDS, the composition of the lung was exactly as in non-ARDS patients. How can you say that is the same thing? I think the emotion play a lot in this fight or in this passionate debate. Nothing to do with science. This, to me, is more than enough. Somebody has to explain me. How can you call classical ARDS something like that? Of course, the time is important. This is an early phase. After 3 weeks, for the few patients that progress to 3 weeks, the picture change or may change completely. And that gas volume and lung compliance are related, we found 30 years ago, and we have the same regression line, even in COVID. If the compliance is 50, 60, 70, means that the gas volume is more than 1.5 liters, maybe 2 liters, 2.5 liters. And this poor guy with maybe 30 of PO2, I put 20 of PEEP because the PO2 is low. And you say, well, the PO2 goes up. Oh, yes. What's about the hemodynamics? What's about the distribution of hemodynamics? What's about the kidney? What's about the price I pay to keep the hemodynamics normal? And this is bacterial pneumonia versus COVID pneumonia. This is closer, the gas content closer, close to the sternum and close to the vertebra. You see at each lung level, so the lung is divided in 10 levels from sternum down to the vertebra, at each lung level, the gas content is almost double. For the same PF, in this case, PF was 108, if I remember correctly. So close to the severe RDS in both groups. What's about the perfusion? Now, in classical RDS, here I have hypoperfusion because I have density and because I have a vasoconstriction. In COVID, I have hyperperfusion because I lost completely the control of the perfusion. Here, you see, okay, this is a good lung. I'm very happy. Now, it's completely unperfused. It's completely unperfused. This in classical RDS is hypoperfused. In COVID, is hyperperfused. How can you say the same thing? And how you pretend to treat it equally? And you say recruitment, recruitability, prone position, great. Awake, semi-awake, completely sleeping. Now, let's see, this patient, supine 5, prone position, redistribution of density, we found exactly the same more than 20 years ago in a classical RDS. And if I put Eiger PEEP here, I have a recruitability, which is great, it's 39%. And this is one patient in intensive care. Now I look at this patient, not the same patient, another patient in intensive care. They look very similar, but look, when I put in prone position, the density stay up, do not redistribute it. I put recruitment at 35, and recruitment does not appear. So don't ask me, the COVID is more recruitable than non-COVID and so on. Do not make any sense. Depends how the patient, which stage is, how much fluid he got it. We have to measure the things. And I think from our point of view, the destiny of the patient is played during the first day, when the patient has a completely different picture, and we risk to have a disaster with a wrong treatment. Consolidated tissue. In a study which is tremendously difficult to be published, it's still unpublished, in which we have 25 patients, and people say, 25 patients, we have 10 millions of patients. Anyway, these 25 patients were studied at supine 5, prone 5, and supine 35 during the recruitment. To understand the mechanism, I'm not interested if 80% of the patients respond to prone position increase in the PO2. I know since decades that the PO2 goes up. I'm interested to know why 20% did not respond. And are the same patients in which the recruitment maneuver PEEP does not work? Why? Which are the mechanisms behind? And the role, I think, is very clear in this study that I don't know if we will ever publish, is the consolidation versus atelectasis. The white lung we see at the CT scan may be due or to the pulmonary units which are occupied by something, cannot be recruited, or by units which are collapsed. To differentiate, I have to measure at 35, which is open, and what does not open at 35, I can call consolidated. And more is the consolidated tissue in the dependent lung regions, greater is the lack of response to prone position. In a pure atelectasis, beautiful response. In a pure consolidation, worse oxygenation. In this study, about half of the patient at 35 decreased the PO2, not increased, decreased. And about 30% of the patient in prone position, okay.
Sorry, Luciano, just 1 minute.
Perfect.
Please. Sorry.
So I don't want, no, I'm not sorry. Sorry for you. Is a big scandal when we say, well, maybe we can just to put in two baskets we have at the beginning. We have a patient with a good gas exchange, with very, very severe hypoxemia, and a lot of gas content, so that at the beginning of COVID-19 pneumonia. And we simply say, but looking at the practical thing, having results from many places in Italy, if in this patient you wait too much and the patient has a tremendous respiratory drive, which is not correct by the high flow or by helmet and CPAP, and it continues, they deteriorate very rapidly. So our problem was just to try to understand in function of time what's happened to these patients. And when you have a patient like this, makes sense to use higher PEEP. I think the PEEP is a fundamental in all this speech. And even the tidal volume. If with 6 I have a plateau of 18 and I have hypercapnia, why should I not use 8? While in type H, after days and so on, we have less response to prone, less response to recruitability because the consolidation goes up. So this is the final slides. You can see that how personally see the course of this disease. You have early, intermediate, and late phase. Oxygenation is always worse, but at the beginning is due to the VAQ. And versus the end may be also the true shunt, which play a role. The atelectasis at the beginning are not present. So the recruitment is not, is nil. But if as soon as they come in intensive care, they put, the septic, 2 liters. Where go the 2 liters? How much we make of atelectasis, that means edema, in these patients. And of course, the CO2 and consolidation goes up. And when the CO2 goes up, I mean the structural changes of the lung. And of course, each of this time has his own specific treatment. That's it. Thank you for the attention.
Thank you very much. Neil, welcome.
Good morning. Thank you very much. I feel like this is a bit of a David and Goliath debate. You get to guess who's David and who's Goliath. These are my exposures. So we're talking about COVID-19, and for the first few months of the pandemic, this was the typical evidence-based pyramid that we were using, where anecdotes rated just under Twitter and TikTok as your most valuable sources of literature. And this debate that we're having actually has been raging in the public press for more than a year. This was a CBC article that a reporter based in Rome was interviewing Professor Gattinoni about. And meanwhile, on my side, maybe you're here to hear this Neil Ferguson. Sorry. We'll try not to talk about doom and the politics of a catastrophe today. No. So there's been, as Luciana's pointed out, there's been lots written about different phenotypes and responses to treatment for the thousands of patients that we've been looking after with COVID-19 over the last year and a half. And one of these seminal papers was this case series highlighting differences in compliance and oxygenation that Luciano has gone over. So I'm going to, for the sake of time, skip through this, but just as at the end of his talk, Luciano was telling us about the type L and type H patient, the low elastance versus high elastance phenotypes, and the hypothesis that patients may transition from one to another over the course of their illness. And there are data to support these hypotheses from careful physiological studies in a single center. Also point out, though, that there are also data from other centers, similar 30 patients with ARDS single center, whose conclusions are different. After establishment of mechanical ventilation, COVID-19 patients follow typical ARDS physiology, these authors conclude. But if we were to think about this, if this hypothesis is patients present with low elastance and progress to high, then initially we would see these things, that patients would have high respiratory system compliance and we should therefore use lower PEEP, that we might see transitions over time where compliance is decreasing, that most patients would not be recruitable, at least early on, and most patients would have low lung weight. So let's just see this. And although there have been some reports here, as you see, with low elastance, high compliance, a lot of published case series have shown compliance levels in the more typical ARDS range. And a number of smaller studies really haven't shown this progression of worsening compliance over time. What about recruitability? And therefore maybe not using proning? Again here, COVID-19 patients actually having a good response to prone positioning. And the authors, again, the conclusion here is the main features of the respiratory mechanics, response to treatment, similar in COVID versus non-COVID ARDS. And lung weight, well, clearly a large case series from Italy here, a difference in baseline respiratory system compliance between COVID-19 and not, but in the subgroup of patients who had autopsy and lung weight actually measured directly, the difference is there, but maybe not that striking. So my opponent here has written this, and I actually completely agree, that we believe that COVID-19 teaches us an important lesson, that diversity of disease requires different ventilatory treatments. But I guess my position is, we already knew that. That's part of ARDS in general. And this is heterogeneity. This is a concept of heterogeneity of treatment effect that Luciano himself has demonstrated. Patients, this is in the pre-COVID world, 20 years ago almost. Some patients with ARDS are highly recruitable. Some patients with ARDS are highly not recruitable. Patients have different in response to PEEP. In this example, depending on their baseline PF ratio, if they, on average, had a PF ratio less than 200, we saw reductions in mortality. On the other hand, if they had a PF ratio above 200, mortality was increased by using higher PEEP. Carol and Calfee shown similar things, comparing a hyper and hypoinflammatory phenotypes within ARDS, showing differential responses to PEEP. In one group, in the hyperinflammatory group, PEEP lowers mortality using higher PEEP. In the other group, which is larger, by the way, using higher PEEP increases mortality. So ARDS always has been heterogeneous. So is COVID-related ARDS. And so I think that the same rules apply. We've seen heterogeneity of treatment effect even within COVID-19, where we see differences in the response to dexamethasone, depending on the severity of respiratory failure, of oxygenation failure. We've also seen that treatments that work in COVID-19 also work in non-COVID ARDS. Similar responses in the pre-COVID world in terms of treatment effect for dexamethasone in this trial led by Jesus Villar. And in a meta-analysis putting all of steroids for ARDS together, you can see, in fact, that the treatment effect, if anything, is slightly higher for non-COVID ARDS than for COVID ARDS. Other treatments like extracorporeal membrane oxygenation, report from the ELSO registry, similar outcomes in COVID-19 patients as we've seen in the pre-COVID world. Skip this for the sake of time. So our take is that the same rules apply, not that everyone should get the same treatment, but that we should use the same sort of physiological-based, applying evidence-based medicine through a physiological lens and tailor treatment as we always should have been doing. So my point was COVID-19 ARDS is like ARDS, that is heterogeneous. Mechanics and physiology, at least in some patients, and often later on in the disease, can be similar to ARDS, to typical ARDS. We already know the heterogeneity of treatment effect is well described. I think we always should have been tailoring PEEP to recruitability, and that COVID-19 ARDS seems to have a similar response to many therapies as typical ARDS. So I think if Tom Petty were here, not this Tom Petty, that Tom Petty, instead of in this nice retrospective about how it really happened, in the cards was ARDS, is the title of this piece, he might change this to, and in the ARDS is the cards. And with that, I'll stop and take questions. Thank you very much.
Thank you very much, Niall. So thank you, Luciano. Thank you, Niall. Maybe, Luciano, you can come to the stage and we will open the discussion with the floor. Is there any question in the room? Yes, please.
Thank you. I think both presentations are complementary to each other, I think, because maybe Professor Gattinoni just explaining what's heterogeneous about, the COVID ARDS is just the L and H type. Maybe the compliance is, higher, and we don't need this high PEEP. My question is to Professor Gattinoni, what about the awake boning? It works with a lot of patients in early COVID, and this means that it works. I mean, you said that there's a problem with the perfusion, and the boning will not work as such in COVID, but we see a lot of patients improve on awake boning, which
Okay, two things. Well, my friend Neil, he didn't touch one point. We're speaking about the compliance, heterogeneity, and so on. Now, the mechanism of hypoxemia is completely different at the beginning. You like or you dislike, is there. And if the mechanism, so you can say not, the physiology is similar. The physiology may become similar at the end of the story, but at the beginning you have a black lung with good compliance, and everybody forget the hypoxemia. It's the association between the two which is lethal. What's about the awake? The awake at the beginning, I mean, we contributed to the proposition, so I know quite well the argument. I know quite well the CT scan. I know quite well the extracorporeal CO2 removal, all these kind of things. Now, the proposition at the beginning, when we say only rescue in L-type, because of the workload to the nurses compared to the possible advantage. In L-type, you improve the gas exchange, okay, but as soon as you are again in supine position, you lose this advantage. And you don't have the requisite, the prerequisite of prone position to influence the outcome, which are a better distribution of stress strain, because in type L, the stress strain are nicely distributed. This is why I become a little bit furious when I hear this, because I know some unit, Bergamo, Bergamo had 60% mortality during the first wave. You remember all the cadavers getting out from Bergamo. In the second wave, they start to look, decrease the compliance, decrease PEEP, decrease the strength. The mortality was 10%. And other people say, of course, the people was less severe. The treatment plays a great role. But once again, at the beginning, of course, at the end, the compliance goes down. And at the end, the respiratory treatment, I touch overall the higher PEEP at the beginning and the smaller tidal volume. These are two main points. Because you say you treat differently, but the people go at home, takes the PEEP and 5 or 2 tables, and end up with 20 of PEEP.
Yeah. I think that we agree a lot on this, that you know,
no, we hate the pro and con because is
that COVID or not, maybe COVID is it's more obvious that there are, and we're seeing so many more patients that the volume of these sort of atypical ARDS patients are more. But in everybody, whether it's COVID or influenza or whatever, if the chest X-ray is relatively black, and then they probably don't need a lot of PEEP. I agree.
Well, it's just observation. Maybe it's time to think if the term ARDS is still useful. Because in one side, we have the running versus the personalized medicine. And reflect the syndrome is lumping together different things, is exactly the philosophical counterpart of personalized medicine. So if somebody say, I want personalized this treatment in a syndrome, is an oxymoron in my classical culture. So you just have to think, cannot stay together, because are black and white.
Neil, Luciano, sorry, we have to conclude. Just a question, a point. We understood that your position is different, but my question is, in front of a patient with normal compliance on very severe gas exchange, my guess is that you will set the ventilator probably in the same way, Neil and Luciano. This is my question, and it means that your different points refer to recommendation, global recommendation, but at the level, at the scale of treating the patient, probably you are able to collaborate together in the same way. I'm wrong or not?
No, I think you're absolutely correct.
See, my only point is that the NIH panel of experts and the Surviving Sepsis campaign still recommend to use the same treatment and a PEEP selection as in classical RDS. My recommendation, before to rise the PEEP, sit down and think on what you are doing. Yeah, and it should be done in every patient.
I think that should be done in every patient. And I think that to your point about lumping or splitting, maybe, I don't know whether it's ARDS or whether it's non-cardiogenic hypoxemic respiratory failure, I hope this is going to turn into a term like breast cancer, where we have breast cancer, but the oncologists don't treat breast cancer. They treat hormone-positive receptor types of breast cancer, which are totally different than that, but they're still all lumped together under a syndrome.
If you use ARDS as a term of communication, good. But when you read in the papers, 40% of the doctors missed the diagnosis of ARDS, big scandal. Doesn't make any sense. It's a word of communication, and we agree. RAS, you have one ventilator, white lung, ear, black. Okay, yeah. But I think it's time maybe to rethink, because now with the definition we have RDS, we have everything is RDS. It's just a little bit of bilateral information. PO2 lower than 300 is RDS.
So thank you very much, Luciano. Thank you, Neil, for this very interesting debate. Thank you, everyone. Thanks, guys.